Multiple sclerosis represents a prototypical autoimmune disorder targeting the central nervous system, characterized by a complex interplay of chronic inflammation, demyelination, gliosis, and neuronal loss. The disease course can be relapsing, marked by episodes of neurological deterioration interspersed with periods of remission, or progressive, with a steady decline in function. Importantly, MS is disseminated both in time and space, meaning lesions occur at different times and in various CNS regions, a hallmark that underpins its clinical heterogeneity. Globally, the prevalence exceeds 1 million individuals in the United States alone, with millions more affected worldwide. The clinical trajectory remains highly variable, but recent advances have significantly enhanced our understanding, leading to the development of effective therapies, particularly for the relapsing forms, and have improved long-term outcomes for many patients. Turning to epidemiology and onset, MS typically manifests between the ages of 20 and 40 years, though cases outside this window are not uncommon. Slightly later onset is observed in men, but women are affected approximately 3 times more frequently than men, highlighting a significant gender disparity. The initial presentation can range from severe to trivial symptoms, often leading to delayed recognition. Interestingly, some individuals harbor radiologically isolated syndrome, incidental MRI findings suggestive of MS, without any clinical manifestations. This underscores the insidious nature of the disease and the importance of imaging and early detection. The initial symptoms of MS are diverse and largely depend on lesion location and severity. A thorough neurological examination may reveal unexpected findings, emphasizing the importance of a comprehensive assessment. The most common initial complaints include sensory loss, 37%, optic neuritis, 36%, weakness, 35%, paresthesias, 24%, diplopia, 15%, and ataxia, 11%. These symptoms reflect the multifocal nature of CNS involvement. Focusing on sensory and visual symptoms, paresthesias, tingling, prickling, often described as pins and needles, are prevalent, as is hyposthesia, which manifests as numbness or a dead feeling. Patients may also experience unpleasant sensations such as feelings of swelling, wetness, rawness, or a sensation of being tightly wrapped, indicating abnormal sensory processing. A sensory level, typically involving the trunk or legs, suggests spinal cord involvement. Pain is common, affecting over half of MS patients, and can be localized anywhere, often changing in location over time. Visual disturbances are frequently due to optic neuritis, which presents with diminished visual acuity, dimness, and reduced color perception, particularly affecting the central visual field. Symptoms can range from mild visual blurring to severe loss, though complete blindness is rare. Periorbital pain often precedes or accompanies the visual loss and is exacerbated by eye movements, a hallmark feature. An afferens pupillary defect is usually evident, and fundoscopy may reveal a normal optic disc or papillitis, optic disc swelling. Following an episode of optic neuritis, optic atrophy is a common sequela. Uveitis is uncommon in MS and should prompt consideration of alternative diagnoses. Motor symptoms encompass limb weakness, characterized by loss of strength, reduced speed, impaired dexterity, and fatigue, often leading to gait disturbances. Notably, exercise-induced weakness is characteristic of MS. Upper motor neuron signs, such as spasticity, hyperreflexia, and extensor plantar responses, are frequently observed, reflecting pyramidal tract involvement. Facial weakness may occur due to pontine lesions, mimicking Bell's palsy, but typically without associated ipsilateral taste loss or retroauricular pain. Spasticity, spontaneous or movement-induced muscle spasms, is common, especially in the legs, and can be painful, significantly impairing mobility and self-care. Interestingly, in some cases, spasticity may serve a compensatory role in supporting ambulation, and aggressive treatment must be balanced against functional needs. Visual blurring may result from optic neuritis or diplopia, which can be caused by internuclear optomoplegia, INO, or sixth nerve palsy. INO manifests as impaired adduction of one eye with nystagmus of the abducting eye and often a small skew deviation. Bilateral INO is particularly suggestive of MS. Ataxia, characterized by cerebellar tremors and dysarthria, scanning speech, reflects cerebellar involvement. Vertigo, often sudden, arises from brainstem lesions and can resemble acute labyrinthitis. Hearing loss is uncommon, but can occur. Turning to paroxysmal symptoms and cranial nerve involvement, brief episodes lasting 10 seconds to 2 minutes with high frequency, up to 40 episodes daily, are typical. These are characterized by no alteration in consciousness or EEG changes, and often resolve spontaneously over weeks to months. Triggers include hyperventilation and movement. Manifestations include Lhermitte's phenomenon, an electric shock-like sensation radiating down the back or legs induced by neck flexion, and tonic spasms affecting limbs, face, or trunk, as well as dysarthria, ataxia, and sensory disturbances. These symptoms stem from spontaneous discharges at the edges of demyelinated plaques that spread along nerve fibers. Cranial nerve symptoms involve neuralgias and spasms affecting the trigeminal, facial, and glossopharyngeal nerves, typically involving their root entry-exit zones. Trigeminal neuralgia in MS often presents before age 50, with bilateral involvement, objective sensory loss, and pain that is less paroxysmal, distinguishing it from classical trigeminal neuralgia. Facial myokymia, rapid flickering facial muscle contractions, is another hallmark. Heat sensitivity is a distinctive feature, exemplified by Uhthoff's phenomenon, visual blurring during hot showers or exercise, resulting from transient conduction block in demyelinated axons. Symptoms can worsen dramatically during febrile illnesses, underscoring the importance of temperature regulation in management. Bladder dysfunction is prevalent, affecting most MS patients. Detrusor hyperreflexia, impaired suprasegmental inhibition, leads to urinary frequency, urgency, and nocturia, while detrusor sphincter dyssynergia causes hesitancy, retention, overflow incontinence, and recurrent urinary infections. Gastrointestinal and genitourinary symptoms include constipation, bowel urgency, incontinence, sexual dysfunction, manifesting as decreased libido, impaired sensation, or in men, impotence, and in women, diminished vaginal lubrication or spasms. Cognitive impairment, often mild, encompasses memory loss, attention deficits, executive dysfunction, and slowed information processing. Difficulties in shifting attention and problem-solving may interfere with daily activities. Although euphoria or emotional ability, suitable or affect, can occur, they are relatively uncommon. Importantly, significant impairment in daily functioning due to cognitive deficits is rare. Finally, psychological and fatigue-related symptoms are prominent. Depression affects approximately half of MS patients, often reactive or endogenous, and can contribute to fatigue. Fatigue itself is the most common reason for work disability among MS patients. It is exacerbated by elevated body temperatures, depression, effort and activities of daily living, and sleep disturbances, such as nocturnal awakenings for urination, highlighting the multifactorial nature of this debilitating symptom.